Hello everyone. In this session, we are going to discuss about meningococcal meningitis. It is a continuation to the chapter Epidemiology of Communicable Diseases. The objectives to this session are definition, problem statement, epidemiological triad. The epidemiological triad includes the agent factor, host factor, and we will also discuss about the environmental factors of meningococcal meningitis. Mode of transmission, pathophysiology, clinical features, diagnosis, treatment, prevention and control, following the general management, and lastly, we will discuss about the summary to our session. To begin with, the definition of meningococcal meningitis. It is also known as cerebrospinal fever, involving mainly the brain and the spinal cord, is a acute communicable disease caused by Neisseria meningitis. The cerebrospinal fever is an acute disease which has a sudden onset, rapid progression, and it declines either in death or recovery. So it is an acute disease, communicable disease. It spreads from one person to other. It is caused by Neisseria meningitis. When we study about the agent factor, we will discuss about Neisseria meningitis in detail in the upcoming slide. You can see the picture of meningitis, meningitis caused by Neisseria meningitis. So we can have a clarity when we discuss in the further slides. So you can see here the normal brain with the normal spinal cord, and this is a baby which is suffering with meningitis where the brain is infected, the spinal cord being infected with bacterial meningitis. Moving further to the problem statement. Meningitis, the distribution in the worldwide, occurring sporadically and in all outbreak in most parts of the world. So we see that it is a sporadic disease. It occurs haphazardly here and there. Also, it is an epidemic disease. Outbreaks are also seen in most parts of the world. In some regions, it is an endemic disease, but it may also alternate with devastating, unpredictable epidemic. So the meningitis can either occur in a sporadically, that is a sporadic form where the diseases will occur haphazardly, few here, few there. So it can occur sporadically, or it can be an endemic disease are diseases which are having a usual frequency. Epidemic. What is an epidemic? Whenever there is an unusual occurrence of a disease in the region or community in excess of the expected occurrence. If the expected occurrence was 100, every year 100 cases of meningitis are occurring in that particular area, so that becomes an endemic. Just if the 100 cases turn out to be 1000 cases, then it turns out to be an epidemic. Unexpected occurrences in excess, whenever the frequency is excess, then we call it out as an outbreak or an epidemic. The endemic, we know that the disease is constantly present within that geographic area. In the usual expected frequency, it is usually present. So how is the meningitis distributed all around the globe? It can occur sporadically, it can occur as an endemic situation, also alternates with a devastating. What do you mean by devastating? A very destructing, unpredictable epidemic. This is the case in African meningitis belt, which is the region in sub-Sahara Africa, which is stretching from the Senegal in the west to the Ethiopia in the east. You can see that the African meningitis belt. It is spreading starting from Senegal, and the belt spreads all around the way to Ethiopia. So the African meningitis belt, which is in the region of Sahara Africa, sub-Sahara Africa, which is stretching from Senegal in the west to Ethiopia in the east. We saw that Senegal in the west, Senegal in the west to Ethiopia in the east. It is in sub-Sahara Africa. Okay. This region is inhabited by around 400 million people. In African meningitis belt, the World Health Organization definition of meningococcal epidemic is more than 100 cases per 1 lakh population per year. How have the World Health Organization given a definition in cases of the meningococcal belt? More than 100 cases, okay? There's some error. More than 100 cases per 1 lakh population. Clear? We saw that the region, how many people are inhabited there? 400 million people are living there, and if the cases are more than 100 cases per 1 lakh population, then it is defined as an epidemic. In the endemic countries where the usual frequency is there, the incidence of more than 10 cases or 2 to 10 cases or less than 2 cases per year per 1 lakh population per year is characterized to be high, moderate, and low endemicity respectively. If there are more than 10 cases, now it is the African thing was an epidemic. So we are considering more than 100 cases per 1 lakh population. We are very well aware of the definitions. What is an endemic? Usual frequency. Epidemic, excess frequency. So here they are discussing about an endemic. A small number of proportion of cases will occur every year in that defined geographic area, and it is a very constant frequency. So we name it as more than 100 cases, more than 10 cases per 1 lakh population to be high, 2 to 10 cases to be moderate, and less than 2 cases as a low endemicity respectively. An outbreak outside the meningitis belt. Okay, we saw the meningitis belt in the sub-Sahara African region extending from the Senegal to Ethiopia. So whenever the outbreak is outside this meningitis belt, it is defined as a substantial increase in the meningococcal disease in a defined population above that which is expected to be the place and time. So whenever the outbreak is occurring outside this meningitis belt, we see that there is an increase in the invasive meningococcal disease. During the recent years, the several outbreaks are affecting. Numerous countries have been affected. You can see the tropical and temperate zones of the other countries like America, Asia, Europe being affected with meningococcal meningitis. We see America, African belt. We saw Africa from Senegal to Ethiopia, which is the belt, and here it is an epidemic, more than 100 cases. The other countries per 1 lakh population we considered, but in the other countries it is spreading, that is Europe, Asia, and America. Several outbreaks are also noted in these countries. In Europe, now let's discuss in Europe what's happening. In Europe, the incidence of disease is ranging from 0.2 to 14 cases per 1 lakh population, and majority cases are caused by the serogroup B strain. Okay, let's see what is the disease ranging from. Here in Europe, 0.2 to 14 cases. 0.2 to 14 cases in Europe. In America, the incidence of disease is ranging from 0.3 to 4 cases per 1 lakh population. Now, in America, in America, 0.3 to 4 cases, okay? 0.3 to 4 cases. Lastly, in Asia, meningococcal disease is caused by meningococci, which is belonging to the serogroup A and C. So the serogroups, that is the subtypes, also varies. We will discuss in detail in the next slides about the serogroups, various subtypes of meningococcal meningitis. Here we have the serotype B, C, and Y in cases of United States. And in Asia, we have serogroup A or C. So in United States, the majority of cases are caused by the serotype B, C, and Y. Meningococcal disease is endemic in India. It is an endemic disease in India with a usual frequency every year. Cases are reported sporadically or in small clusters. Moving further to the epidemiological triad, which is the most important section with respect to our preventive medicine, community medicine. The most focused part is the epidemiological triad. Also, from your university point of view, from your examination point of view, you need to focus upon the epidemiological triad of each of the disease. So, in cases of meningococcal meningitis, so far we are very clear what is the causative agent of meningococcal meningitis. What it is? It is the Neisseria meningitidis. And meningitis, delicate organism which dies on exposure to heat and cold. You can see the organism's picture here. We have the Neisseria meningitidis which dies on exposure to heat or cold. It is a gram-negative organism. It is a diplococci. You can see the image very beautifully given. It is a diplococci. It is gram-negative organism. It is a diplococci. Coffee bean shaped bacterium. See, you can see here they are coffee bean shaped bacterium. What is the source of infection? Organism is found in the nasopharynx of case and the carrier. So where can we find the organism? It is found in the nasopharynx. Okay, I don't have the picture. It's in the next few slides. I'll show you the picture in the next few slides. So the organism is found in the nasopharynx, of the cases and the carriers. You can see the organism to be found in the nasopharynx of the cases and carriers. The cases may be mild or asymptomatic nasopharyngitis. The cases will present with nasopharyngitis. 4 to 35% of the population is harboring the organism during the inter-epidemic period. One epidemic comes and then the disease remains silent, and again the outbreak occurs. During this two outbreaks, the inter-epidemic period, 4 to 35% of the population will be harboring this organism without any prominent symptomatic presentations. The period of communicability. Until the meningococcal are no longer present in the discharges from the nose and the throat, they are communicable. Cases will rapidly lose their infectiousness within 24 hours of specific treatment. So we see that the disease stops to be communicable once the discharges reduce. Clear? The period of communicability. We are clear with it that until the meningococci no longer present in the discharges, they are communicable. Cases rapidly lose their infectiousness within 24 hours of specific treatment. If we give a specific treatment to the case is the individual who is presenting with the signs and symptoms. So once the symptomatic treatment is given, the infectiousness stops within 24 hours. Moving further to the common forms of occurrence of meningitis. So, we have meningitis which is involving the brain and the spinal cord. The meningitis is involving the brain and the spinal cord. In cases of septicemia, the meningitis is involved, and meningitis which is causing the blood poisoning, or it can also result in the combination. Moving further to the serotypes. The causative agent Neisseria meningitidis is a gram-negative diplococci which is having 12 serotypes. So far the 12 serotypes have been identified. They are the groups A, B and C, 29E, HIKL, W135, XYZ. Can you go through it again? ABC, HIKL, XYZ. Along with that, 29E and W135. Based on the structure of the polysaccharide capsule, there are various types. Okay, these subtypes or the serotypes are based on the structure of the polysaccharide capsule. You can see here the picture. Based upon this polysaccharide capsule and the structure, we have various forms A, C, W135, Y, 29E, HIKL, XYZ. Okay. Other disease conditions seen by the same infection. Before going to the other disease condition, you also know that the majority of the invasive meningococcal infections are mainly caused by the serogroups A, B, C, X, Y, and W135. The meningococci of these serotypes have the potential to cause the endemic diseases, and also they have the potential to cause the outbreaks. The other disease conditions which are caused by the same infection are meningococcal pneumonia, meningococcal bacteremia, purulent pericarditis, osteomyelitis, endophthalmitis, conjunctivitis, primary peritonitis, and urethritis. So, the other diseases caused by the same infection we have gone through, affecting the various organs, the eyes, ophthalmitis, conjunctivitis, then the peritoneum, peritonitis, urethra, urinary tract, so urethra, pericarditis, the heart, bones, osteomyelitis, and the entire blood. So, we have meningococcal bacteremia, lungs, pneumonia. Moving further to the host factor. During the epidemic, the carrier rate may go up to 70 to 80%. So, who are the carriers? Carriers is an individual who is not having the prominent signs and symptoms. He does not come up, he does not present with all the signs and symptoms. He remains in a dormant stage. He does not present the signs and symptoms, but he is having the organism within himself. So epidemic is the carrier. During the epidemic, the carrier rate may go up to 70 to 80%. Moving further to the age and sex factor. This is predominantly a disease of the children and a disease of young adults. It is affecting both the sexes with the highest attack rate in the infants age 3 to 12 months. So what is the host factor we saw, guys? The age. Predominantly the meningococcal meningitis affects the children and the young adults, and it affects both the sexes equally. Highest attack rate 3 to 12 months. Moving further to the immunity. So the younger age group are susceptible than the older age group because antibodies are lower. In cases of younger age groups, the antibodies are lower. All the age will be susceptible. Yet in that, the younger age group are more susceptible than the older age groups because of their antibodies being lower in number. Immunity is acquired by subclinical infection mostly, and clinical disease or vaccination. Infants are deriving the passive immunity from their mothers. Okay, how do we acquire the immunity? Because of some subclinical infection, mostly subclinical infection. Sometimes the clinical disease itself is giving us the immunity to prevent the further contraction of the disease, or the vaccination provides us the immunity against the meningitis. Infants are deriving the passive immunity from their mother. Moving further to the environmental factors. I hope the agent factor is clear and the host factor is clear. Now we will discuss about the environmental factors. The seasonal variation, it is frequently in dry and cold months of the years. The seasonal variation of the disease, it is well established. The outbreaks occur more frequently. So seasonal variation is well established. Outbreaks will occur more frequently in the dry and the cold months of the year. The dry and the cold months of the year, probably from December to June. Overcrowding as it occurs in the schools, it occurs in the camps, barracks, refugee camps, and all of these is an important predisposing factor. Incidence is greater in the lower socio-economic group. The incidence is found to be very high in lower socio-economic groups who are living under the poor housing conditions with exposure to tobacco smoke, HIV infections, and their travel to the endemic areas can also result in the development of the disease. Are you clear with the environmental factor? So the environmental factors are the winter months, dry and cold months, that is from December to June. Second factor is the overcrowding, which is occurring in the schools, camps, refugee camps, etc. And then the lower socioeconomic status and travel to endemic areas. Asplenia is another condition where there is an absence of spleen, HIV infection, and travel to endemic areas. Moving further to the mode of transmission of meningitis. It is a droplet infection. The transmission is through the upper respiratory tract infection. It transmits mainly through the upper respiratory tract infection, or it can also spread through the direct contact with the saliva of an infected person. Infection is invariably acquired from the healthy carrier rather than a person with the disease. So a carrier without any signs and symptoms who is healthy yet carrying the organism around, he is the main source of infection rather than the person with the disease who is isolated in the hospitals, who is taking the treatment. He is less communicator of the disease. The healthy carriers who are not taking any treatment, who are not isolating themselves, who are not taking any sort of precautions, are the main sources of the transmission. Case fatality rate in meningitis is 20%. Moving further to the pathophysiology, one of the most important aspect for your practice. So we need to know what is the pathophysiology behind each disease. Now let us try to understand what is the pathophysiology behind meningococcal meningitis. Initially, there is nasopharyngeal colonization. So, once there is a transmission of the microorganism via the nasopharynx, via the upper respiratory tract, then comes the colonization. Nasopharyngeal colonization. What is colonization? Colonization is nothing but the presence of a microorganism with its growth or the multiplication of the microorganisms which is occurring in the nasopharyngeal wall without any clinical expressions. Okay, just colonization occurs where the microorganism is settling, growing, multiplying. You can see here the Neisseria meningitis, where the organism is entering, it is localizing. Okay, then comes bacteremia. Bacteremia is the presence of the bacteria in the bloodstream. So the bacteria is entering into the bloodstream after the local invasion. You saw in the picture here, the bacteria enters the nasopharynx. The bacteria entering the nasopharynx, colonization of the bacteria, nasopharyngeal colonization occurs, and then the invasion of the bacteria into the bloodstream. You can see in the bloodstream the bacteria is entering. The bacterial invasion, bacteremia. Endothelial cell injury, it is causing the endothelial cell injury, and meningeal invasion. So the meningeal invasion occurs. How? The bacteria will penetrate the blood-brain barrier by invading the brain's microvascular endothelial cells. Okay, by invading the microvascular endothelial cells, it will cross the blood-brain barrier and enter into the meninges. That results in subarachnoidal space inflammation. You can see in the picture here, the bacteria colonizing, entering into the bloodstream, crosses the blood-brain barrier. The bacteria is crossing the blood-brain barrier and then enters into the subarachnoid space. You can see that the bacteria, after damaging the endothelial cells, it invades the meninges and causes the subarachnoid space inflammation. You can see the subarachnoid space. It is causing the inflammation in this area. I hope the anatomy, you're aware of the anatomy. Let us just quickly go through. We are discussing about the meningitis. So let's discuss about the meninges in the first place. This is the skull, dura mater, arachnoid mater, pia mater, and then the brain. So these three layers will constitute the meninges, and the spaces. We have epidural space, subdural space, and subarachnoid space. And there is an inflammation of the subarachnoid space. There is increased CSF outflow resistance. So here you can see that there is an increased CSF outflow resistance, and the increased CSF outflow resistance results in hydrocephalus, which causes the interstitial edema. So we can see in the picture here, once the bacteria will enter the CSF, they will grow there, causing the inflammation, and this inflammation is leading to the collection of the exudative material in the subarachnoid spaces, and the exudative material is blocking the CSF outflow. The CSF outflow is blocked. As a result, there is hydrocephalus, interstitial edema, and whenever there is edema, there is an increased intracranial pressure, which is causing a decreased cerebral blood flow. You can see that there is an increased pressure which is causing a decreased blood flow. It also results in, whenever there is an endothelial cell injury, it increases the blood-brain barrier's permeability, leading to vasogenic edema. Vasogenic edema again results in increased intracranial pressure and decreased blood flow. You can see in endothelial cell injury causing the blood-brain barrier permeability to increase, and the increased blood-brain barrier permeability leads to vasogenic edema. What do you mean by vasogenic edema? Vasogenic edema is characterized by the extravasation or the extracellular accumulation of fluid in the cerebral parenchyma. Because of the disruption of the blood-brain barrier, the fluid is getting accumulated in the cerebral parenchyma, which is again leading to the increased pressure and decreased blood flow. And the subarachnoid space inflammation also causes the cerebral vasculitis, cerebral infarction, again thereby decreasing the blood flow. Cerebral vasculitis, the blood vessels are also getting inflamed, and once there is inflammation, there is exudation, decreased blood flow, cerebral infarction, and decreased blood flow. The subarachnoid space inflammation leading to cytotoxic edema and increased intracranial pressure, decreased blood flow. So what is cytotoxic edema now? Cytotoxic edema is a type of edema when the cells, particularly the astrocytes, are swelling up because of the influx of the exudative water and the ions. So that leads to the swelling up of the astrocytes, the cells which are present. Clear, guys? So what's happening? Let's revise again. Nasopharyngeal colonization. So the nasopharyngeal colonization leading to local invasion enters the blood-brain barrier. You can see enters the blood-brain barrier. Then it causes subarachnoid space inflammation. Once there is a subarachnoid space inflammation, it is causing a disruption of the tight junctions, disruption of the blood-brain barrier. It causes a damage to this, and then it leads to the accumulation of the fluid, resulting in the CSF outflow resistance, hydrocephalus, interstitial edema. In the brain, there will be interstitial edema, increased intracranial pressure, and decreased blood flow, resulting in meningitis. Moving further to the clinical features. The clinical features of meningitis. So the baby might have a tense or bulging soft spot, high temperature. Fever is there, so there's a high temperature, but it is often absent in the babies under 3 months. The baby may be very sleepy, having a staring expression. He's too lethargic, too sleepy to even wake up. The breathing will be fast, difficulty in breathing, extreme shivering, pinprick rashes, marks, purple bruises anywhere in the body. You can observe them. Sometimes the baby also has diarrhea. Then we also have vomiting, the baby refuses to feed, loss of appetite, blotchy skin, paler skin, turning blue, cyanosis will be there, a stiff body with the jerky movements, or else there could be a floppy body, lifeless. Okay, pain, irritability from the muscles, aching pain, severe limb pain, joint pain, cold hands and feet. Are the clinical features clear? What are those? From top we are coming. 1, there is fever, then lethargy, rapid breathing, then in the skin there are prick, rashes, blotchy skin, cyanosis, paleness, pallor. Sometimes there is diarrhea, vomiting, loss of appetite. The baby becomes very irritable when picked up. They have high pitched moaning or crying. Muscles are irritable. There is severe joint pain, limb pain. You can see, we'll see the other symptoms. We have nuchal rigidity. So what is nuchal rigidity? Nuchal rigidity refers to the neck stiffness, which is caused by the bacterial meningitis. The baby can have lethargy, irritability, apnea, apathy. Apathy is nothing but the baby becomes completely indifferent to his family, to his loved ones, to his parents, and he can also have pallor, jaundice, shock, hypoglycemia, convulsions, anorexia, which is nothing but the loss of appetite, coma, fever, tachycardia, diaphoresis, and weakness, photophobia, seizures, headache, and aching muscles. You can see in the picture here, fever, loss of appetite, high-pitched moaning crying sound, dislike of being handled, it is becoming fretful, pale, lethargic, blank expressions, neck retraction with aching of back, stiff neck, photophobia, headache, fever, vomiting, drowsiness, joint pain, etc. So most of the cases are asymptomatic and serve as a reservoir of infection for the others. So these cases, events, they are asymptomatic, they are affected, then they are the carriers. They serve as a reservoir of infection for the others. In general, the susceptibility to the meningococcal disease is decreasing with the age. So we see the sudden onset of the disease. It is an acute infectious disease. Person has intense headache, fever, nausea, vomiting, photophobia, and stiff neck. Neurological changes, like we discussed earlier, includes drowsiness, irritability, mood swings, confusion, seizures, photophobia, hearing impairment, visual impairment. So we are moving further. More complicated condition, the conditions can start with the patient can get affected with cognitive impairment, neuromotor disability, and memory disturbances. You can also include these in your clinical features. You can list a number of them now. Also include the neurological changes. Under the neurological, those basic symptoms, we are very sure of them now because 3 times almost we have discussed it. Lastly, we are adding on the new things are cognitive impairment. Okay, cognitive impairment, visual hearing impairment, neuromotor disability, and memory disturbances. For your answer to be more presentable to your professors, you can add these points. Moving further to the prognosis. The cases can be fatal within 24 to 48 hours. In 5 to 10% of the cases, unfortunately, the cases can be fatal within 24 to 48 hours, despite the prompt antimicrobial treatment given in a good healthcare facility. Though the baby was admitted in a very good hospital and the doctors gave the prompt treatment, yet there is a chance that the baby can lose his life within 24 to 48 hours in 5 to 10% of the cases. Even those children who survive, up to 15 to 20% of them will have the permanent neurological sequel. What were the neurological sequels we saw? The cognitive impairments, hearing impairment, and then auditory impairments. Hearing is auditory, and then we have visual impairments, a memory problem in such children. Meningococcal septicemia, there is a rapid dissemination of bacteria in the bloodstream. So we see in septicemia what's happening, there is a dissemination of bacteria in the blood. That is the reason emia. Septicemia, when the bacteria is disseminating in the bloodstream, yet it is a less common form of meningococcal disease. It is characterized by circulatory collapse, hemorrhagic skin rashes, and a high fatality rate. The meningococcal septicemia, when the bacteria disseminates in the body, in the blood, then the patient presents with circulatory collapse, hemorrhagic skin, and high fatality rate. Moving further to the World Meningitis Day. The World Meningitis Day is celebrated on April 24 annually Until 2022, it was celebrated on April 24. Now it is moved to October 5 to accommodate the greatest number of participants. The World Meningitis Day recently is celebrated on October 5th. It is observed globally to raise the awareness about meningitis. So what do we do on the World Meningitis Day? We increase the awareness about meningitis disease, which the protective membrane surrounding the brain and the spinal cord is becoming inflamed. We tell that meningitis is a disease where the protective membranes, the meninges which is surrounding the brain and the spinal cord, is becoming inflamed. To make people aware, we can tell that there is a swelling which comes in these membranes. It is essential to determine the cause of the meningitis because treatment varies depending on the cause. Confederation of Meningitis Organization COMO has utilized the World Meningitis Day annually since 2008 to raise the awareness of meningitis as a global public health concern. So COMO, they have raised the awareness of meningitis. They have considered it to be a public health concern, and they have raised awareness since 2008 on the day of World Meningitis. So, what was the logo? The Join the Fight to Eradicate Meningitis by 2020 was the slogan adopted on 2024 by the World Health Organization. Moving further to the diagnosis. During the physical examination, we need to check the presence of any signs of inflammation, any signs of infection. What are the signs of inflammation? Then we have redness, the paleness, loss of function, heat. Okay, all such signs you have to check. And if there is any infection, note carry on the physical examination and note the signs. Next comes the blood culture. The blood culture, the microorganism is observed under the microscope, and this culture will show the presence of the bacteria. The imaging like CT scan or MRI scan of the head is done to know the swelling or the inflammation which is present. And lastly, we have spinal tap, a definitive diagnosis of meningitis. Once we require a definitive diagnosis, we have to opt for spinal tap. So we need to collect the cerebrospinal fluid. In the next slide, we will see how can we collect the cerebrospinal fluid. In people with meningitis, the fluid often will show a low sugar level. So when the CSF analysis is done, it shows that the sugar levels are low and there is an increased white blood cell count and increased protein. Analyzing the fluid also helps us to identify which exact bacterium is causing the meningitis. So this is a picture of the CT scan report of bacterial meningitis. So you can see in the picture here the CT scan, which shows first we know that these are the axial flare images of the brain. So the axial flare images of the brain, and which shows the mild ventricular prominences. You can see the mild ventricular prominence and increased flare signals within the convexity cells. You can see it's brighter than the CSF within the ventricles. This brighter part within the ventricles is the increased flare signal within the convexity salsa. You can see the increased brighter part than the CSF. You can see the increased intensity. Okay, so this is the CT scan report, and again this is the MRI report of the bacterial meningitis. I told you we will discuss about the spinal tap, how we can draw the CSF and then do the analysis. On analysis, what did we see? Low sugar levels and increased white blood cells, and we also see the infection. What to expect during a spinal tap? First, we lie the patient on the table in a fetal position. Then the doctor injects the anesthetic to numb the lower back. Once the anesthesia is given, then the needle is inserted between the lower backbones. You might have observed in your OT, if you have any posting, or you yourself as a surgeon, you might have observed the anesthesiast coming and giving the injection anesthesia to the lower back, and then the needle is inserted between the lower backbones and a small amount of the CSF is drawn. Moving further to the prevention and control. The tips for preventing the meningitis is we shouldn't share the personal hygiene items with others, and wash your hands often, especially whenever it is exposed to any sort of germs. Scrub your hands often, disinfect the surfaces regularly, avoid any close or a prolonged contact with others who may have the infection. Try to avoid a prolonged contact or a close contact with the infected person. Moving further to the vaccine. Currently available meningococcal vaccines include the polysaccharide vaccine and polysaccharide protein conjugate vaccine. You can see currently available are meningococcal vaccines are polysaccharide vaccine and polysaccharide protein conjugate vaccine. The conjugate vaccines are more immunogenic and also induce immunogenic memory. Okay, you can see here the conjugate vaccines are considered to be more immunogenic, and they are also inducing the immunogenic memory. Both the vaccines are available against the meningococci of serogroup A, C, W, 135 and Y. Let us write down here. We have two vaccines. What are the two vaccines? The two vaccines are polysaccharide vaccine. The first one is a polysaccharide vaccine and the other one is a polysaccharide protein vaccine. Polysaccharide protein vaccine. Polysaccharide protein conjugate. Okay, polysaccharide protein conjugate vaccine. So the polysaccharide protein conjugate vaccine are to be more immunogenic and they are inducing the immunogenic memory. They are more immunogenic and inducing immunogenic memory. But both the vaccines are available against the serotype A, C, W, 135 and Y. Let us discuss about the polysaccharide vaccines. Internationally marketed meningococcal polysaccharide vaccines are available in a bivalent form, that is A and C, or a trivalent form ACW135. International AC. How can you remember polysaccharide international AC? It is in the bivalent form AC. It is internationally marketed. So internationally marketed meningococcal polysaccharide vaccine available in a bivalent form AC, trivalent form ACW135. ACW135. Then a quadrivalent form is also available, ACW135. Adding on to it is a serotype Y formulations. The vaccines will contain 50 μg of each of the individual polysaccharides. Meningococcal polysaccharide vaccines will be administered as a single dose to a person more than 2 years old. Most of these vaccines will be given subcutaneously. Is it clear? What are the bivalent forms? AC. Trivalent form ACW135. And then comes the quadrivalent form. In the quadrivalent form, we have ACW135 and Y. So these vaccines are administered subcutaneously. The adverse reactions to polysaccharide meningococcal vaccines are usually mild. The most frequent reaction is 1 to 2 days of pain. The most frequent reactions are 1 to 2 days pain, redness at the site of infection, which occurs in 4 to 56% of the vaccine recipients. The transient fever is reported in less than 5% of the recipients. Are you clear with the adverse reactions? What are those? Pain at the site of infection and fever. Most frequent reactions are redness or pain at the site of infection and transient fever. Moving further to the conjugate vaccines. The licensed meningococcal conjugate vaccines are available in a monovalent form. Monovalent in the sense one serotype, it may be A or it can be C, or it is in a combination. We have combination vaccines or quadrivalent vaccines like A, C, W135 and Y. It will also include a combination vaccine based upon the influenza, Haemophilus influenza type B and Neisseria meningitis serotype C vaccines. So it can be in the form of HIB/meningococcal meningitis C, serogroup C vaccine. What is the combination? So let us revise again. Conjugate vaccines can be monovalent. Monovalent, it can be A or it can be C. It can be quadrivalent. In quadrivalent, we know we have A, C, W135 and Y. Or it can be a combination. The combination includes the Haemophilus influenza B / we have meningococcal C subtype. Clear? Serotype. Conjugate vaccine should be given as intramuscular injection. So we see that polysaccharide vaccines were given subcutaneously. They were administered subcutaneously, whereas the conjugate vaccines are given intramuscularly, preferably in the deltoid muscle or in the anterolateral aspect of the upper thigh in the children. It is given in the anterolateral aspect of upper part of the thigh in the children who are aged more than 12 years of age. Okay. Then the monovalent Men C vaccine. Monovalent Men A. First, let's discuss about the monovalent Men A vaccine. They should be given in a single dose to individuals 1 to 29 years of age. We saw that the conjugate vaccines which are available in a monovalent form. The monovalent A should be given to individual in a single dose age 1 to 29 years. For monovalent Men C, meningococcal C, serotype C conjugate vaccine, one single intramuscular dose is recommended for children age more than 12 months, to teenagers and also to adults. Clear? Monovalent meningococcal A is given to children and the individuals age 1 to 29 years. Men C is given to children aged more than 12 months, teenagers and adults. Children 2 to 11 months of age require 2 doses administration at an interval of at least 2 months. Is it clear? And also we will give a booster dose about 1 year thereafter. Quadrivalent vaccines. What are the quadrivalent vaccine? A, C, W135 and Y. They are administered in a single dose to an individual age more than 2 years. So how do we store the vaccine? So we discussed about the booster dose, quadrivalent vaccines. Now we will discuss about the storage. Meningococcal vaccines should be stored at 2 to 8 degrees Celsius. Conjugate vaccines are preferred over the polysaccharide vaccines because of their potential for herd protection and their increased immunogenicity. We discussed that conjugate vaccines are preferable because of their increased immunogenicity, because of their increased immunogenic memory which they provide. Also, it is preferred over the polysaccharide vaccines because of the herd protection, because of the immunogenicity, increased immunogenicity in the children less than 2 years of age. Both the vaccines are safe when used during pregnancy. The World Health Organization recommends that the countries with a high or medium endemic rates of invasive meningococcal disease and the countries who are also experiencing this frequent epidemics, they should introduce the large-scale meningococcal vaccination programs. Thereby, we can prevent the epidemics, outbreaks, control the endemics of the meningococcal meningitis. So moving further to the general management, we need to keep the hands clean by washing them, disinfecting the surrounding surfaces, also avoid the close contact with the infected person and never share the personal hygiene items like we discussed earlier. Moving further to the summary. That is the last part of this session, the summary to the meningococcal disease. I hope you guys are in a position to explain to me in a more better form the meningococcal meningitis. To begin with, okay, it is like a quiz to you guys. To begin with, what is a meningococcal disease? It is an acute cerebrospinal fever is an acute infectious, acute communicable disease. It is caused by Neisseria meningitis. How is the transmission? It is communicated through the upper respiratory tract. It is a droplet infection and also from the saliva of an infected person. Babies, small children, young adults are more at risk. What are the symptoms? Fever, vomiting, headache, stiff neck, backache, nausea, photophobia, confusion, rashes, red or purple rashes. And it can be difficult to notice the symptoms in babies and young children, and only few signs of illness may be present. So some of the symptoms we should be alert are high fever, unusual crying in the babies, refusing to eat, there is loss of appetite, vomiting, changing in the sleep patterns, seizures, and purple rashes. Early treatment will save the lives. So immediately we need to visit the nearest healthcare facility so that you can save your loved ones if you experience the following symptoms which we discussed earlier. Clear? So this was the summary to the meningococcal meningitis. With this we come to an end of our session. I hope all of the slides were clear to you, and if you have any doubts, put them down in the comment section, and if you like the video, hit the like button, subscribe and share it to your friends. Thank you.